Okay, so first off, welcome everybody to our March 28th edition of the South Dakota Healthcare Coalition Fireside Chat. We've kind of been down since before the holidays, and we haven't had one in a couple of months. So we're glad to get back up and running. These are always a lot of fun. We never know, just to let everybody know, these are unrehearsed, so we never really know where they're going to go. But they're always good and they're always interesting. So this month we are extremely delighted to welcome the new Secretary of Health for the state of South Dakota, Melissa Magstadt. So just a little bit of a background and a little bit of an introduction for Secretary Magstadt. She comes from boots on the ground healthcare response, and I say healthcare response and not just as a healthcare provider, because he was one of the original members of, I believe before it was Sanford, the Sioux Valley Emergency Management, IMAT Emergency Management Team. So she goes back in crisis response back to the early days, and amazingly, she's only 24 years old. And we called that group the Red Jackets because we had these red Sioux Valley jackets that said Hospital Incident Management Team on the back, and we were extremely proud of that group. We made tremendous strides in emergency management organizationally, and it became more of a corporate response group, and it ultimately evolved into what it is today over at Sanford. But Secretary Magstadt has remained within the realm of healthcare all these years, and now she is the Secretary of Health for the state of South Dakota, and we're extremely excited about that. In previous conversations, for the coalition, this is for us, we just feel like this is such a great opportunity. She has a extensive interest in preparedness. She has an extensive interest in emergency medical services, and is a fine advocate for preparedness in multiple areas. So I want to welcome Secretary Magstadt to our fireside chat, and I'll give you a couple of minutes to add more to that introduction, and then I'll fire into the first questions, and then we can just go from there.
Oh, it is so good to be here this morning as well. It's just I just feel like, getting to talk to folks in emergency preparedness, emergency response, having been an emergency room provider, these are like my people. It's like, these are my people. These are the ones that, been over the same journey with them as well, been in these discussions. And I think, back to those years with, Sioux Valley, I mean, if that takes you back in time. And then the little red chevron heart thing that was part of it. Wow, where we've came and what we've gone through and what we've shifted through as the time's gone back, including, having discussions back, a dozen years ago or so, or maybe a little further than that, in pandemic response for the H1N1 bird flu. I mean, that was sort of like the beginning of what pandemic response would be when it comes to like healthcare sort of crisis. And it was the H1N1 sort of thing that spurred on some of that funding back and then. But, it got the conversation started back then. And we've sort of evolved, and, it looked different than what we thought. But I remember when my little community was looking at their pandemic response, we pulled out the old binder of the discussions that we had a little over a decade ago, about pandemic response. So, we're on the backside of that and sort of learning all these things. And I bet we all have a top 10 list that we learned from COVID. I bet everybody has that list. And I know I have one. But so what my job is now is I'm a nurse practitioner by trade, and have worked in clinics and long-term care and also emergency care. And I've been in healthcare for 33 years. So at that point, you really do start getting this long list of things that you've enjoyed having done, people you've interacted with, and things that you've learned, and it becomes this little encyclopedia that you can draw from. So then the governor called me on, and she and I had, how this sort of came about is the governor and I, when I was running for legislative office over a decade ago, she was running for her first stint in Congress, and I was running for my first place as in the State House of Representatives. And so up in this Northeast area, we end up doing an enormous amount of parades together. So when you're running for office, you do a lot of parades, a lot of kissing babies, a lot of shaking hands. And so we had met and developed a friendship at that point. And through the years, we've had discussions back and forth about healthcare and healthcare policy and pandemic response and COVID, and where does healthcare government start and healthcare private sector patient end. And so we had those discussions. And then in the middle of December, the governor gave me a call and asked if I would consider being her Department of Health secretary. And so I had to do a little bit of research. We sort of have an interesting setup in our government. We have the Department of Health, which has a piece of healthcare. We have the Department of Social Services, which has a piece of healthcare. We have the Department of Human Services, which also has a piece of healthcare. So, and each one serves different sort of populations and goals. Now, the Department of Health, and the reason I said yes to the Department of Health was it has things in it such as emergency preparedness and response. So how prepared we are as a public to deal with crisis, and how developed are our emergency management sort of systems. And that is right along my old heart kind of work. But we also have disease preparedness and monitoring. So, COVID was a big deal underneath us. We have chronic disease prevention, so diabetes prevention and opioid overdose prevention and suicide prevention, all of those things, which are definitely emergency response types of things. You've all worked in the emergency room. You've all picked up patients with opioid overdose, suicide attempt, that sort of stuff. So that's right in my purview as well. And then we're also get the joy of helping start pregnancies and early childhood health. That is part of us as well, is that we get to help support young new mamas and pregnant moms to hopefully have healthy pregnancies. So like the WIC program is underneath me, immunizations for little ones, measles, mumps, and rubella, and polio immunizations are all under me as well. And then the other weird one is in public health protection, which I think is sort of interesting, is that every time you go into a restaurant and you have this expectation of clean, healthy restaurant, that is under the Department of Health, is that we watch over and inspect all the hotels. We inspect all the restaurants twice a week or twice a year, everybody, and then sort of make sure that the public is protected on that sort of realm as well. So that's kind of the world that I live in, but also kind of a couple different unrelated, well, kind of related, unrelated, is that we are very much interested in workforce development. So healthcare workforce development is very much in my purview and very something I'm really, really interested in diving into that a little bit more on behalf of all the workforce shortages that we all have. And then we also have some healthcare accessibility. So all things telehealth, all things that would reduce barrier to accessibility of healthcare is underneath me. And then the professional licensure conversation. So paramedics, doctors, nurses, pharmacists, dentists, all of those are under the Department of Health as well. So I get the joy of working in the protecting the public's health and planning and watching over. I get the joy of doing that as individuals with their pregnant moms and little ones in our WIC program. And then I also get the joy of supporting the workforce, whether that's developing workforce or that is supporting the workforce that's currently, but also making sure that if we have workforce, that the workforce is developed to the point of practicing at the top of the license. We don't have necessarily the luxury of limited scope of practice. In South Dakota, maybe our practice is only like this, and really the practice could be like this. So we're having lots of discussions on workforce expansion, maybe not even just in the numbers, but in the capabilities of the workforce to do maybe something outside of what they've done before, but are being done in other places and with success. So I'm very excited about those conversations as well. But that's kind of what what my job is in a really, really big nutshell. And it's such a cool job. It's such a cool job. I've been loving on people and patients and healthcare for so long, and that it makes, I never would have anticipated having this job, but I'm really enjoying having this job on behalf of the people of South Dakota. It's been a great pleasure to move into this, watching over, taking care of patients, taking care of people, and taking care of the people who take care of the people, and letting that sort of be a shift in my career. So it has been a joy for sure. And I'm also glad to be here because I also know that you guys are in that same business, right? The same business of taking care of the people, but also taking care of the people who take care of people. So, and improving the systems in which we function in. And I remember when this coalition was just a baby, like it was a baby coalition way back. And it was almost a discussion of concept of what this could possibly be. And then here you are years later, this functioning group of people that are making a difference for our state. So again, you're around here long enough that you see things in infancy and ideas, and all of a sudden they become mature, thought-provoking, influence-making, couldn't do without you sort of entities. And it's been really cool to see that come in, because I remember you, Greg, and I were having this, I didn't even, was that a decade and a half ago, about a potential for a coalition, this thing that could connect people together and could be something that are influential and beneficial to the state. So yeah, how cool is that? I mean, I love it. You've been around long enough, you get to see these cool things come into order for sure.
And what's cool about it, we started actually having right around the same time as the now notorious picture of the Red Jackets, which will ultimately, we won't hope it winds up in the South Dakota Hall of Fame, right? But we started doing concept papers on coalition development in 2008. I have some documentation that goes back to like kind of before it was cool to have a coalition. We were talking about having a coalition in the state of South Dakota. And what's interesting about the concept paper and the org chart that's in it is almost exactly what we have now. So we were kind of, I don't want to say, well, maybe I will say, we were kind of visionary in the sense that this is what actually makes sense and works for us. But it's really funny that you brought up.
Someone has to have the vision though, right? Someone
Mhm.
has to have the vision to even start planning it. So visionary, yeah, absolutely.
And I think that we have a lot of people now who have a lot of really good ideas. I just wanted to, you sparked me with the bird flu story, because we recently, as a group, I sent this picture out to let everybody know. I sent this picture out. I found it randomly on my computer, and I sent it out to the people that I still had email addresses for in the picture. And we started talking about the first pandemic flu plan. And I remember that time frame is like, it was something was going on in Asia, and the federal government wanted us to have this plan, and we were all struggling to like figure out what are we going to do about pandemic flu. And we were talking about this the other day. The book The Great Influenza was kind of like the guidebook at the very
Guidebook,
beginning.
influenza, the great influenza, it was called, from 1918. Yeah.
Yep. And that was like the guidebook of anything that we needed to know or try to figure out. And we built a pandemic flu plan, and ultimately I think it grew to about 6 inches thick. I have the original binder with all the research and stuff in it, and I think I might have donated it to Matt Van Voorhis over at Sanford, because when I was leaving, I was like, all right, this is this is part of the history of Sanford's emergency management. I think Matt wanted it, but it's like this giant binder. And then when the actual first pandemic happened, the one that came out of Mexico, nothing in the book, in the plan, actually fit, because we were planning for all these hospitalizations and all of that, and we had all of this great information that didn't work. And it really talks about the evolution of healthcare response to being more all hazards, and having capabilities for surge that again, it doesn't really matter, I think, what's
Matter what it
causing
is.
the surge, more than that it is, and how our focus has changed, like you said, over the years. So and now on that note, from the coalition's perspective, as we have some big strategies ahead of us. as far as where we want to go. So one of the things that we really want to do is, and we're working on, is including all the county emergency managers in our coalition. So right now the Healthcare Coalition has the board has approved, I believe, 5 at-large groups. So SDHCC, SDHCC, the South Dakota Emergency Management Association, the South Dakota EMS Association, the Ambulance Association, and EMS for Children. So I think that's 6. And part of that is to start really enhancing our capabilities with our partners to bring it all together. And one of the previous conversations that we had in Fireside, and I know this is something that you are very interested in, is the expansion of EMS and really assisting EMS in growth. So I want to kind of go there first. I mean, we can definitely, go in any direction you want. But one of the things that the coalition wants to do is, so we discussed this vision that EMS is really kind of in the middle of 2 worlds, right? So they're defined as first responders, but they really are healthcare professionals. So when you define an EMS provider, agency, or EMS in and of themselves, I've had this long-standing, I guess, call it pet peeve, that we mischaracterize them as first responders, and they miss out on all the healthcare exercises because they're not really included. It's more like, well, EMS will do this for us, without really bringing EMS to the table and having them define their real roles. So it's always like, yeah, we've got to decompress 30 patients, so EMS is going to do that for us. Okay, next objective. And suddenly the hospital is less 30 patients. So our goal in our coalition is to actually move EMS more into the healthcare realm. They are the first professional healthcare providers that are seen in disaster on scenes. And we need to start expanding that. So what are some of your thoughts on EMS in South Dakota, particularly, I guess, in the rural areas, and how we can all come together and enhance and strengthen that?
Well, that's such an interesting topic, and it is so timely. So 2022, which before I was Department of Health, in the Department of Health, but this very concept of the continuum of healthcare, where does it start, where does it end, who has this job and who has this job, was being discussed. And the governor put $20 million of her budget in 2022 to be all EMS service focused, right? For this, for a couple different things. One of the drivers is that we have a workforce problem. The other one of the drivers, we have a rural health, we have a rural state, and there's a lot of space with little people in it and very few folks in it. And then, yet we still are seeing this volume of services going up. We're seeing there's certainly a complexity of patients increasing, but also an increasing an amount of things that really shouldn't be in the emergency room, that don't really need to go to the emergency room. And yet, if someone's using emergency services, there's this thing that says, well, if the ambulance came, it has to be taken to the hospital kind of paradigm that we've sort of was functional in the past, but maybe is not necessarily as functional or as needed. And so we've kind of got all of these sort of global things that are going on. So we've got some funding. We've got rural healthcare and the delivery of it being challenging. We've got a workforce challenge of, and you and I were talking about this the other day, the mass exodus of the workforce out of not even just healthcare, but out of everything. And where did all the people go? They left after COVID, and there's this mass and here we are with an unemployment rate of only 2%, which is so wonderful to sort of talk about. But the flip side of it is that it is very hard to find people to work, not only in your entry-level work positions, but in healthcare. These are not entry-level work positions. These are trained, make certifications, must have a certain level of even national certifications and licensure requirements and all that kind of stuff. So healthcare has a little bit harder sort of thing, because we have these standards that have to be, you can't have an unsafe person take the place of a professional such as a paramedic, EMT, that kind of stuff. So so that means that there's change being driven. which, I'm someone who really embraces change and I really enjoy changing, but I also know that, change in these kind of things has big impacts, and it has, ripple effects to go down from generations after. So the things that we are thinking about changing and doing have to be well thought out, and to make sure that the generation that comes behind us doesn't suffer because we made changes or did something that wasn't really well thought out. So there's a few things that are going on that I think are going to be really monumental, and I am so excited about this. So we've got some practical things going on. A lot of our ambulance services needed their life packs, or their, the defibrillator sort of machines taken care of. Life pack does about 94% of the market here in South Dakota. So that's why we went with them. But life pack and just changing out old equipment. So very practical kind of things. We have another initiative called Telemedicine in Motion, where and we're planning like on 60 ambulance services by the end of May, having this ability to have an on-site emergency room physician, emergency room nurses. And I think they're going to start adding paramedics like on-site in their ER computer hub, that the minute the rural ambulance system pushes this little button on the ambulance wall, that entire team is there via cameras and microphones and all those kind of things. Now, we've had some really interesting outcomes of that. One of the first ones to go up was in central South Dakota. And that first patient was a buffalo goring. Now, there's not very many states that are going to have buffalo gorings as part of their EMS services. And this was picked up by a little rural emergency EMS ambulance, and they pushed the button. They'd only had the service for like 3 days, this telemedicine, pushed the button, and the entire team came on and helped sort of give some direction as to, oh, can you look at that a little bit closer? What's going on over there? But really just listened in and put the entire transfer together. So the patient was brought to the closest small rural hospital. At that point, the airlift was already in play. And 20 minutes after the ambulance arrived in the small rural, they were in flight. So the nurses didn't even get their paperwork done before the patient was in flight to the tertiary center. And that was 3 days into the launch of this project. And it really spoke to this way it was supposed to work. It is supposed to be people who arrive in the ambulance with you virtually, and they make sure all things are organized and smooth the pathway to get you to the best place. And it worked like a dream. And the people that were in the emergency or in the ambulance said they were non-invasive, they were helpful, they were useful, but weren't a bother. And ended up being one of those things that if you have to try out a new system of care, why not go into the deep end of the pool? Because it tested out and it worked wonderfully. And we'll have 140 services, I think, by the end of, don't quote me on that number, but somewhere by the end of the year. But we're gonna have 60 live ones by the end of May. So those are like, to me, that's like this shiny penny. It's really cool. It's like, and now it's being talked about in Forbes, and it's being talked about in various national magazines. And, that is just really cool. And then there's the other project that maybe is like really, it's kind of the ugly stepsister project, but it's the really, really important project, which has to do, and we've hired a consultant for this. And so the work is just starting on the sustainability of rural healthcare long-term. And what does that mean? And what does it look like? And what does it need to happen to do so? So that is going to be done this year. And we are diving into these deep conversations. And I know there'll be people that are on this phone call. My God, if that wasn't old, this Zoom, that phone call was so 2000s, right? The Zoom meeting, which is, now, so 2020, that there will be people that are on this conversation that will be at those conversations as well. And you are critical people to those discussions about sustainability in rural emergency medicine, because, there's a demand for it to be sustained. And yet you have this different shifting, even in like about 70-75% of our emergency services are volunteer. They're volunteer services. And so it counts on, like in my little town of Castlewood, it counts on the Castlewood people volunteering to do so and showing up and doing the certifications. But it also means that during the daytime hours of 8 to 5, that you are working in Castlewood. And if, most small towns, the people leave to go work in the town that they live closest to. I mean, that's where the jobs are, right? So they drive there. So my town empties out, but for a couple people on our EMS services, and one's having back problems. And so what are we going to do when she leaves and can't do it anymore? And yet from 8 to 5, the entire town still has people in it, but a good chunk of our volunteer EMS services, they work other jobs over in Watertown. So, that's kind of like the milieu that we're functioning in. But so that conversation to me, like I said, it might be the ugly stepsister and the cool things that we are doing, but that's the discussion that is really the deep one for the long term and for what will be the next generation of healthcare. Now, my other really cool project, and this was spurred by a group of paramedics. And you know what I love about paramedics? Like, they're the cowboys of healthcare. They're the ones that, go right out into pioneer, frontier, first on the scene. I just love that spirit. And maybe it's the South Dakota girl in me that just loves that, but I absolutely love the paramedic cowboy spirit. I think it's fantastic. But they brought a bill that was sort of very interesting. And what this bill would have done is that there currently are paramedics. There's the Board of Medicine, and there's 5, 6, 7 physicians that sit at the top of the Board of Medicine, and there's all these little subgroups underneath. They're called advisory committees, and these subgroups are professions such that make recommendations. Then it has to go up to the Board of Medicine, the medical staff up here, to approve, disapprove, do disciplinary action. But the paramedics are in that. They're underneath. So are occupational therapists, physical therapists, athletic trainers, dietitians. They are all these little subgroups, advisory committee subgroups, that when they make a recommendation of scope of practice, or when they make a recommendation on licensure, discipline, that sort of stuff, licensure changes, it has to go up to another profession, the physicians, to evaluate that for the review of literature and the disciplinary actions regarding scope of practice. So it happens at this level, and then there's another level that they have to go up and get that approved or disapproved or whatever it is. And then the Board of Medicine, the physicians, are the ones that give the go ahead, for instance, for physical therapists on dry needling, which is kind of an acupuncture technique that the physical therapists have embraced, and there's data that supports that it's useful and that the physical therapists are trained in this. Yes, they are. So 2-3 years ago, the physical therapists wanted to add dry needling to their scope of practice. Well, the advisory committee had to do their work, and then they had to take it up to the Board of Medicine, like the medical group, for them to do the review of literature, decide if that was good, and then said yes to the dry needling practice expansion. So, which maybe doesn't sound like a big deal, except for when your profession is really trying to become a profession that has its own body of knowledge, like you guys do, like the paramedics do, like the physical therapists do. There is a body of knowledge, there's evidence-based, there's science-backed, there's training, there's certification, there's all these things in place that every healthcare provider at the professional level has to do in their practices. So there's these levels of bureaucracy that were put in when Governor Janklow, and so this was back in the 1990s, when Governor Janklow saw these professions coming up and they were in their infancy, and he and the legislature at that time just said, okay, we'll just put them under the Board of Medicine, and you'll all just have advisory committees underneath that. And at that time, we had infancy of practice, right? Paramedics, emergency medicine, what is it, 40, 50 years old? And, you were just kids at the time. Now I would say you're middle-aged, and you probably have the right to somewhat self-determine and have your own sense of direction in what you do as a practice. So we are and we were just having this discussion. Our first one is with our our advanced life support personnel on, I think it's April 3rd or 4th or something like that. We are meeting with that group of stakeholders to break out what does the practice look like. Because as you were saying, Greg, you said something was really interesting to me. That healthcare sort of puts the paramedic in the first responder, but not really a part of the healthcare team. What I've noticed with the paramedic themselves and EMS, they also put themselves in that same category, that we do just this right here. And it's like, no, you are a gateway, you're a part of the team, but healthcare has put them there. But what I've noticed is that we've got a little mind shifting to do with the people who are traditionally have been in the ambulance, to bring them to the table, but also lift them up so that they understand that you have a body of knowledge that you own. You have a set of skill sets that no one else has. You have capabilities that other healthcare providers do not have. And you should have the right to self-regulate. You should have the right to self-discipline your fellow paramedics and EMS personnel as you see fit, just like the nurses do. The nurses do this. We don't have a set of physicians that sit over the board of nursing. The nurses self-regulate the nurses. And the paramedics now have grown up, and EMS services just in general have grown up to have that kind of maturity. And then you should be able to decide what credentials, what constitutes the education and training that a paramedic should have for the licensure that we want to give them in South Dakota. So these are all conversations that are going to be taking place over the next few months, not only with the paramedics, but with occupational therapists and dietitians who all sit in this two-tiered system. If I have to say that this one I am so excited about, because it has to do with a profession that has now grown up into its maturity. So you might be 40, 50 years old, but you're middle-aged now. You have the right to somewhat self-determine and decide what you want to, what's going to be a part of paramedic scope of practice, what's going to be a part of EMT scope of practice. You have the knowledge base and the maturity of the profession to be able to do that now. And I suspect what's going to come out of those work groups are things that do lift up the profession to having that ability to self-regulate and self-determine. And to your point of this, of that you are no longer just the first responders. We passed a bill last year, and we confirmed it again this year, of the community paramedic, which is, our old statute said a paramedic, an EMS person, is a person who practices in the back of an ambulance. And that's how our statute read. This is where you practice. Well, now we are putting paramedics in telehealth kind of capabilities. We are putting them in the community and allowing them to go out and see patients outside of the ambulance. And we have some data back from Rapid City already that this trend of going in more and more higher transports was bent over this last year, because they put a community paramedic program in. And instead of having to take a patient in for a stub toe, it was treated and trained and taken care of there in the moment. Or I've also seen in Minnesota, in a community I worked in as a traveler, I was there as an ER provider, critical access hospital. I was there the year before they put the community paramedics in, and I was there the year after it was instituted. And the year after, the amount of what I would say not needed, non-urgent calls that came to the emergency room dropped down. The amount of what I would say critical patients that would came to us. And now we were butted up against an Indian reservation. So, that's always challenging healthcare calls. But because the community paramedics were going out and they were seeing those people who were chronically ill, they were seeing those folks that were frequent flyers of the emergency medical system. They were going out and finding those patients before they were sick. And so they didn't come into the ER so much. They came to their primary because they could adjust the fact that you gained 5 pounds overnight in fluid. And you didn't come to the ER in acute heart failure. You went to the clinic and they got you a little bit higher diuretic and took care of it that way. So I am really excited about possibility for expanding that you practice at the top of your licensure rather than at this level that's being defined by another profession. gosh, I saw some technology for even fast exams, the quick ultrasound exam, handheld device about this big. And I saw a video on it, a paramedic using that right in the back of an ambulance to check and see if there was a pericardial effusion, check to see if there was blood in the abdomen. And at that point, make those interventions if need be to either, take care of it in the field or to alert the hospital system, the emergency doctor and staff know that when they come back, they have a pericardial effusion that they're going to need to address. And we know that right from the field. And then all of a sudden, all those pieces on the emergency backside, we're prepared for the pericardial effusion that was diagnosed and found in the field. I mean, but if we don't have conversations about how to keep that open and how to get you at the top of your license, and I think the first one is the ability to self-determine what is our scope, what will we allow in our state, and then readjust that as we go on. The Board of Nursing is going to take on a little bit of that expansion of role with LPNs, and they have a
Can anyone else hear me?
I think
Yeah,
I heard.
it looks like Melissa froze.
Yeah. Let me shoot her a text.
Send her a message.
Hopefully she'll see it. She kind of went blank on, I think did we lose her completely now?
Yeah, I don't see her on at all.
Yeah, she's probably rebooting. There
Oh,
she
she's
goes.
back.
Yes.
Hold on,
on
let me mute you. You got to unmute yourself.
and I was like moving to phone, right? The levels of technology,
You're not allowed to
redundancy
use the
in
telephone. We don't
systems,
use telephones anymore.
right? It's like redundancy in systems. Don't we talk about that all the time? Business continuity. There we go.
Mhm.
That was so weird. All of a sudden it was like, oh, hey, am I here anymore? So to me, these are really, really exciting. What I would say is game changer conversations. And, I have legislators, senators, and representatives that are ready for the statute change. So we've been in conversation with them. The bill was brought by the paramedics. It didn't pass. I'm going to be full confessions here. I had to oppose it, and I hated to have to oppose it because I wanted to do it right. But I also made a promise to do it right. And my job now is to be held accountable by not only the legislators, but the paramedics who brought that bill, but also to you. And then I have a personal accountability, and I have skin in the game on this one as being a healthcare provider that has worked alongside some of the best providers I've ever worked beside have been, when Chris chooses us the ambulance only. And it's like, no, we're in a different place. Plus we need it. We can't just be so limited in what we're doing because the demand requires that we have to let loose of some of these things. And, other states are doing it. Maybe there's other things states aren't doing that we could be the first ones to do. And I'm also fine with that as well. And I think someone I saw pop up in the chat wanted to be a part of that stakeholder group. So if you would just email me that, I'll tell you, the jumping on of the conversation has been really cool to see. That means people actually care about this, and they want to be a part of the solution making, which I am absolutely thrilled about. But they're jumping on with the occupational therapists, they're jumping on with the dietitians. And so what that tells me is this is a really important conversation for healthcare right now in South Dakota. And it's one of those pivotal sort of moments in life a little bit. We're on the backside of COVID. It's in the background now. We've accepted it in the world as being a part of how, the human existence now. And now we get to sort of go, okay, what's this next thing that we're doing? And we won't be so COVID centric anymore, which I'm so excited. because, we made it, we learned. I bet 100 years from now, Greg, don't you think we'll have like the great COVID? It will be the book that everyone looks to and says, how do we respond to a pandemic? Look back to the last 100 years when they had their last pandemic, and let's learn from what they did. So I imagine there'll be a book that has sort of like all of these things that we learned, and maybe not even relevant to them anymore, but
Maybe you and I
I am
need to just
excited
sit down
to
and
talk
write
about
it.
this instead. Yeah. The great COVID of 2020.
The great
First chapter
COVID.
will be the great toilet paper famine. That
The
will be the
great-
first chapter.
Yep.
How we all ran out of toilet paper. And there was a run on the
Really?
grocery store.
The great COVID and the search for an open Dunkin' Donuts. That would be like,
Right.
great.
Yes, exactly. How we all would like try to survive without our Starbucks and our coffees that we didn't get to have. And you finally got decided if you were important or not by the word essential. You're essential, you're important. Not essential, sorry, you're not that important in the world.
And and that was really interesting because a lot of people got insulted about not being considered essential staff and initially, and then I think they kind of got comfortable with it. But I remember the terminology, like who gets to stay, who gets to go, who gets to go home, and so on. As you move forward, and getting, just kind of staying on the EMS track, EMS is always considered essential staff, and in so many ways. And it's really cool with all of the different change that is occurring from a perspective of EMS at all. So I've been on it's more of trying to shift a national or create a national paradigm shift back to the original thing that I said, is that we train EMS, and I think you made this point before, we train EMS to think that they are the first responder in the back of the ambulance, and it's
Ambulance
just,
is fine.
yeah, you're in the box, this is where you are, and this is, but we use EMS in different ways, and during, in the National Incident Management System, and many people on this call have heard me complain about this over and over again, and I just spoke at a national conference about it. We create this EMS branch where EMS people are completely uncomfortable with triage, treatment, transport, and it never works in large scale events. It's always chaos and people rushing the ambulances, and ambulances full of people showing up at this location or that location, and there's just mounds of data showing that the EMS branch doesn't work, and it's kind of goes against what the NIMS doctrine says, which says don't change what you do every day. And the first thing that we do is we change what EMS does every day. And basically what EMS does, what makes them different from firefighters and law enforcement, and why I don't really consider them like the pure first responder. And that's not an insult, that's actually, a compliment.
That's a compliment.
Yeah, and it is because EMS goes to the scene, removes the patients, and then they're at the hospital. Their job doesn't end once the patient's dropped off. Then they start working in the emergency room, helping out in disaster. And they also start decompressing. So their role then shifts from, we brought everybody to this one hospital. Now we have to start moving people to appropriate treatment facilities, because the accident may have happened in the middle of a field. And, not that it ever happens, but you could have a bus crash in Madison, South Dakota that has 76 elderly.
Yeah, don't even say that. Knock on wood. I'm the suspicious healthcare provider in me goes, knock on wood. That's not going to happen today. Okay. Don't say such things.
The reason they said that is because we actually had one of those about 12 years ago. And all of the patients wound up at the hospital in Madison. And then the second part of the response, when law enforcement, everybody kind of go back to regular business, is to get those patients to different areas. And, we use our EMS assets, like, air, medical, and ground transport units and all of that. So once we get them to safety, then we move them on. But there's a national trend in the scope of paramedic practice to continue to expand that scope. And I think the interesting problem that you identified here is the amount of people who are able to volunteer at all. We got someone breaking the rules here. Hang on a second.
Someone's got the CCU call on. I love it. This takes me back to my hospital days.
All right, we're all on the way. They're gonna get more than enough people responding.
Yes, we're all coming.
So, you know, one of the problems that we see is volunteerism continues to kind of drop. And this is it's kind of connected to what we were talking about. It's like, where did all the people go? So post 9/11, we had a exodus in emergency services in New York City of fire, police, EMS, people who had been in 20, 25 years, who took the opportunity to get out after that. And we're seeing that again in COVID. But I think you made a really good point. It was a little different there because of the types of training that are required to be, you know, a firefighter or a law enforcement officer or even a paramedic, which requires a little bit more. But
Can't
workforce
pull Joe Blow off the street. No.
yeah, workforce overall is suffering right now, which means that if workforce is suffering, you know, what is happening to volunteerism? And that's a giant chunk of our EMS providers in the state of South Dakota. So, and a little bit more in the emergency management world, many of the emergency managers are not full-time. So, you know, it's like the deputy sheriff,
Right.
it's also the emergency manager in a county.
Got a little two hats going on. Yep.
Yeah, and the weight of the work is okay until something happens. And then you have these dual roles and it becomes overwhelming. And it's a heavy lift for some people who, you know, when you have a community that is functioning and, you know, and you have a cardiac here and a pulmonary edema there and a car accident there, you're able to hold up the weight. But then when you have a large scale event, like a tornado comes through, or whatever, I mean, look at the rail incident that just recently happened in the United States. Like those, we have rail here, those things can happen here. You know, that completely overwhelms the response system. And we need better and better and better processes for that. So, you know, from our perspective, one of the things that came out is, you know, we're working on, and I've told you about this, an EMS advisory group. And everything that we've been wanting to do got put on hold for 3 months. Like we had a hard stop with our audit. And you know,
we had legislative session. Yep.
And never again, we've made a pact in the coalition. Never again will we request anything greater than $749,000. That's going to be our cap.
You don't have to go through that process.
Yeah, because you know, 3 months out of your life is then, you know, explaining what you did with the money that you got over that. And then a really good idea that came out of the project officer, the federal project officer, was instead of having one single clinical advisor, the coalition is now going to create a clinical advisory group, and it's going to contain a paramedic. It's going to have maybe a pediatric intensivist, a trauma doc, an ER doc, and ER nursing.
Broaden the perspective and knowledge. Yeah. Yes.
And then how do we, as a healthcare coalition, support? Because we're not necessarily operational. We're an operational support structure. But what our biggest focus here and our biggest function in the coalition is situational awareness, bringing everybody together to one spot in our command center, which we'll have you come visit next time you're in Sioux Falls. And
love it.
And you know, and we're strategically placed on 18th Street in Minnesota around a lot of decent food. So, you know, we've got a Starbucks up the block. We've got some Mexican food. You know, we've got
sure. Yep.
All kinds
of staples of life.
Yeah, you know, and those things are important things when you're running disaster, to have access to food. But to bring all of that together and then activate a clinical advisory group for an affected location, an EMS group, whatever, you know, kind of wanting to bring all that work together with the work you're doing, and make sure that we're all on the same track instead of working in bubbles. So I think this is a great opportunity, not only for, you know, the expansion of our EMS advisory group, and actually finally getting everybody together. One of the biggest things that they talked about when we met the first time was advocacy. You know, there's always a tendency to throw money at things, and you know, so we have money put on the side, for EMS. You know, we were like, hey, we have this money. Can we buy you something? You know, what can we do?
What do we do with it?
Like a token,
absolutely. That's the harder thing.
And then you go back to normal. And they were like, we don't want anything. We want advocacy. We want to meet with C-suites, executives from rural hospitals to talk about really what we are capable of doing and what we're not capable of doing. So that's something that we're
Yeah,
talking
right.
about putting together with SDHCC. And we have an opportunity now. We're going to be speaking at their conference in September. So they had asked the coalition to do a presentation. I think that's going to be our focus, is bringing together rural EMS and so on. And you and I can talk more about that on what your ideas are for that as well. Because I think now more than ever, at least in the post-COVID world and in the structural changes that we've seen, both with the coalition, what do you call it? We have an opportunity to synchronize everything, and not have
The need for it,
and that project there and this
right?
project here and that project there and nothing goes anywhere. And we have an opportunity now in partnership to synchronize all of the work that we're doing. And we've got a lot of really good work going on in the coalition. We're operational support now. We've got a command center. We're doing cool drills. We're working with folks like the Mountain Plains RDHRS who come to our meetings, and they're sitting here right now. And expanding that work and creating new, just kind of new frontiers for what we do, and
It's exciting times.
we got to be prepared for the next mass buffalo goring. I mean, that was kind of like
Yes.
something that I have never seen before. Like, great, I've been around a long time. I miss the buffalo.
Right.
But mass casualty incidents, in the pure definition of those, it could be a car accident that has 6 people in a community of 500
Which will
people.
overwhelm that person working in the critical care access hospital or critical access hospital. Oh my God, it'd be a nightmare.
Yeah, so I mean, I think
Yeah.
now for the coalition and with the State Department of Health and working directly, with EMS in the state and getting your input, I think because you're so passionate about this work, I think we're going to see a lot of really big changes.
It's an exciting time in this field. Absolutely. And we didn't even mention the 52 to 57,000 people that become more Medicaid eligible when Medicaid expansion goes into place. So what does that mean for primary care? What does that mean for access to care? And what does that mean that falls down on the EMS services when access to care is a barrier over here? Of course, we haven't increased the amount of providers, but we're increasing the amount of patients by 52 to 57,000 in the estimates.
Nothing like taking on a little more challenge. We're up for it.
Right. Yep. Because it all trickles down to and the final lift of all healthcare, that final net for everyone is the EMS service.
Yep. And I think over the years, if anything, you and I have learned in this craziness of healthcare in and of itself is that nothing is impossible, and no is not an option. So I have this. I'm doing this presentation tomorrow, actually, for AHEP, and I threw some pearls of wisdom in there, if I could actually be wise on anything. And I threw a couple of pearls of wisdom in there, and one of them is in the world that we're in, from a response perspective, no is not an option in the world of emergency preparedness and healthcare preparedness. It's more of an opportunity to find a way. If somebody tells you it can't be done, that's a challenge.
It has to get done.
Yeah.
Right. It has to get done some way, somehow. That's what I love about the EMS services. It's the cowboys, the people who say, hey, this happened, we're going to deal with it and get on it. So it's like the cowboys of healthcare, and I totally love it.
It's kind of like the hold my beer moment. No, there's no way we can do that. Oh yeah, well, hold my beer. And we always find a way.
Step out of the way.
So what we're doing, by bringing our area command together is we're providing a central location for all of those folks to communicate and hold each other's beers while we figure stuff out in real time in the middle of disaster.
Yeah.
And there's always as we come to the close of the hour, there's always an open invitation for you to come to our command center, and you're already aware of our exercise in May. And that's going to be a real fun one. And, we're going to drag Brianna and her team into that at Mountain Plains.
I'm going to try to make that happen with my schedule.
Well, we'll just hack into your calendar and clear it for the day. So you'll think you'll have nothing. We have those capabilities in the Healthcare Coalition. So anyway, with about 5 minutes left, any parting thoughts for the members of our coalition on, from our Secretary of Health? And I think that your message is very enthusiastic and exciting. Any additional parting thoughts for
Exciting
the group?
times.
And where do we go from here?
I would totally agree. This is an exciting time. It's a challenging time, but status quo never changes unless there's a challenge. It just remains the same. There's nothing that'll shift it. And so these kind of things breed exciting times to come. And I honestly, on the behalf of the healthcare professionals, just in general, paramedic, OT, PT, these are their times to sort of rise up and really start taking their piece and owning it and expanding it. And I'm excited because it also benefits the rest of us, not only as healthcare providers, but also as citizens.
And one of the things that I think that we learned long ago, again, I was tempted to show the picture of the Red Jackets, but I withheld, because I just don't want people to see how much older I look.
Oh my God, and I had different colored hair. I mean,
yep. Yeah, you're incognito in there, like no one even knows who you are. It's like,
yeah, right. Very
the gal in the back with the red hair. That's Melissa Magstadt. But one of the things that we have learned, and I think that that we've lived in the coalition since I've been here, at least, is that you can't build walls around anything. And if you build walls, it's planning to kind of restrict yourself in situations where you really need to expand. And I think that again, like no is not an option. So if no is not an option, building a fence around knowledge, building a fence around capability is restrictive of the spirit of what we are actually trying to do. So
shoot yourself in the foot. It's to your detriment to do so.
So it's so cool to have you here. It's just really an exciting time, and it's like when we talked, it's like the band is back together. Like it doesn't get any more exciting than getting the band back together. So again, thank you so much. I know you're very busy, especially in this new role. So I really want to thank you for your time and your spirit and your support for healthcare and EMS. We really look forward to all the future work that's going to happen in your tenure. So again, thanks.
So great to have been here with such good people. Well, that's right. No, it's not an option. It's just not.
So that should be the name of the book. No, it's not an option.
Yeah, no, it's not an option.
There we
go. Title's done. Title's done. Now we just gotta actually do the hard part.
Yeah, we just have to write the pages. We're good.
Write the pages.
We'll put it on our list. Okay. So
all right.
Thank you very much. Folks. And we'll chat soon. Thanks everybody for coming. And more information to come out as we work through of the this thing called life. Thank you again.
Yep. Fantastic. Pleasure to meet you all. Bye-bye now.
Take care.
Bye.